because our resources are limited, even here in the United States, where we have so much of our budget allocated to improve health. And during the pandemic, we saw headlines like this. We're short on hospital beds, and hospital administrators were trying to figure out, which patient should have this bed when I have multiple people who need limited resources. And so some of the study designs that I'll talk about today are tools that we can use to answer these questions that come up in real life about which interventions will produce the best outcomes for the most number of people, and how we can use our limited resources efficiently. Not just our hospital beds, but also our workforce. And the special training that people have is very limited, and we need to make sure that we are leveraging all of those skills and expertise in a way that is not putting strain on our healthcare system and our care providers, while still optimizing outcomes for the patients. So that's why, I like the questions that I try to answer using cost analyses, and I'll give a couple examples today. But the questions that we're often trying to answer when we apply these different cost models, they fall into a couple of different buckets in my experience. So first, we can try to assess value. And when I talk about value, we're thinking about what are the health benefits, but also what are the costs, and how can we use the resources we have to achieve the most good for the most people, not just in the short term, but also thinking about their lifetime costs and the long-term impacts of the healthcare system, because sometimes it can take a while to see the benefits of an investment in preventive care or in social risk factors. So we can use these cost tools to look at those benefits in the future and include those in our analyses in a way that a randomized control trial may not be able to do due to shorter time periods in that assessment. The second bucket of questions that I answer are related to implementation of interventions and helping us to understand, is this intervention feasible in this particular context for this system, for this population? And is it sustainable? And if it isn't, how can we adapt the implementation of that intervention to improve the efficiency and make it more sustainable in the future? The third bucket, we often use simulation to answer the what if questions. So what if we change this assumption? What if the outcome that we saw in this trial was, we have so much uncertainty? What if it's at the high end? What if it's at the low end of that estimate? And we can use simulation to understand how the uncertainty in our own knowledge can affect the outcomes for that population. And so that can really help decision makers to have a sense of what the possible outcomes are if they do implement that intervention, because it's rarely a point estimate. There's always a range, and every time you implement something in a new context, you're going to have a different outcome. And so cost analyses can help us to better prepare for what those outcomes might be. So a few different types of cost analyses. One is a business case analysis, where we're looking at the broad context in which the decision is being made, thinking about the mission of an organization and how a particular option might fit in with their long-term goals. And as a part of a business case analysis, you might include a budget impact analysis, because the return on investment is always an important piece of the business case analysis. But it's more limited in scope, where we're really just focusing on the financial costs of an intervention. And then finally, cost effectiveness analysis. And this one is really important because it is the type of analysis where we have a formal method for expressing value as the outcomes, the health benefits that are generated compared to the costs that are expended on an intervention. So we'll spend the most time on cost effectiveness analysis, but I'll give just a few more details on the first two as well. So business case analysis has multiple pieces. As I mentioned, the budget impact analysis is one of those. But we also need to really establish why we are considering these different solutions. What is the problem that we're trying to address that makes this business case important to conduct? And if you don't have a strong need, then you probably don't need to do this business case analysis. Second, you want to look at all the different solutions. So if you're in a clinical realm, there might be multiple potential interventions to address that particular patient need. And so you want to consider all of those so you can compare and evaluate which one will make the most sense in your context. And then finally, after looking at the financial effects, you want to make a recommendation based on that really broad analysis and understanding the mission and the policy context in that recommendation, the future impacts as well. So a budget impact analysis, often conducted as a part of a business case, but also standalone. If you're a healthcare administrator and you really just need to know, is this intervention feasible? Can I even do this? Do I have the workforce? Do I have the money? Do I have the sufficient patient population to make this intervention feasible? This is a type of analysis you could use to answer those questions. And so one example was a randomized control trial for an intervention telehealth program supporting caregivers of seriously ill patients. And so we estimated the cost of the nurse conducting those telehealth visits over 8 weeks following discharge. And then we estimated the revenues that could be generated by that intervention through conventional CMS physician fee schedule dollars, billing codes. And we found that the reimbursement potential was similar to the cost of the intervention on a per participant basis. But we also wanted to inform implementation by looking at those what-if scenarios. So in the control trial, there was a nurse practitioner conducting the calls with the patients. And so we also conducted analyses looking at, well, what if a social worker were conducting those calls? How would that impact the cost? And you could also look at an advanced practice nurse. So those are some of the different ways that we can leverage a budget impact analysis to help support the implementation and dissemination of high value evidence-based programs. So I won't go into a lot of detail here. There are a couple different methods you can use to estimate those costs, and different approaches make sense in different contexts. But I would like to focus a little bit on cost effectiveness analysis, which is the formal assessment of the trade-offs between the health benefit and the cost. So you may be familiar with this type of analysis where you're comparing alternative treatment options and outputting a single measure that incorporates all of the outcomes, including adverse events, including quality of life, including the healthcare system cost, and ideally even patient costs and societal costs. And that single measure is really a key benefit of this type of analysis, because you can look at the cost effectiveness across different interventions to understand the relative value that they are bringing to the healthcare system across many different contexts and diagnoses. So as I mentioned, there are many different aspects of health that we want to incorporate into that single consolidated measure. So death is an important one, but we also want to think about disability and morbidity that affect the quality of life, your functional ability, activities of daily living. Quality of life also includes your mental health and your social support. So things like that are hard to measure, but also really important to consider from a patient perspective, what is adding to the value of their life from their perspective. So we can use across all of these constructs to create a measure of life years and quality adjusted life years. And we do that using an idea called a utility weight. So you can see this has grown out of the economics field where we think a lot about utility. What is the value to a person or to a buyer, consumer? And in this context, the utility weight is a single measure of the health-related quality of life that represents all of those different factors: mortality, disability, and quality. And it's a continuous value ranging from 0 to 1, where 1 is perfect health. And a positive outcome, like a remission from cancer diagnosis, would increase your utility weight, so it would be closer to 1. And an adverse event would decrease your utility weight or disutility. And so we can use that utility weight and multiply that by the number of years up until death. And when you multiply those together, that is the formula for the quality adjusted life year. And this is the most common outcome or measure of health benefits that we see used in cost effectiveness analysis. And if there are questions, please do share those in the chat. I'm going to continue through and take those questions at the end, but I don't want you to forget them. So please use that chat function so we don't miss any of your questions. When we calculate that quality adjusted life year, that is the effectiveness or the health benefit, and that's the denominator in our incremental cost effectiveness ratio. And the other important trade-off is the cost, and that's the numerator of the cost effectiveness ratio. And we're comparing the new intervention to either usual care or a more common intervention, a standard of care. And the difference between those two is why we call it incremental, because we're comparing what is the incremental change in the cost and the incremental change in your quality adjusted life year if we implement this intervention compared to what we might do otherwise. And so this ratio leads to, you could have 4 possible interpretations. If it's more money and a better effect, this is where cost effectiveness can be most helpful because we know it costs more, we know it makes things better, but how much more? Is it too much more? Or is it really a high value because we're paying a reasonable amount of money to gain that incremental benefit? But you can also have these other situations, decreased effect and less cost is an interesting quadrant to consider. But typically we're looking for something that will increase the value and the quality of life. And so as I was saying, is it too much? How do you assess that? And we'll often use something called a willingness to pay threshold. And this number can vary quite a bit depending on the country and the context. And in the US, we often use willingness to pay values ranging from $50,000 for one quality adjusted life year, all the way up to $150,000 and sometimes even more when you're thinking about some precision medicine and really highly beneficial but very expensive interventions. All right, so I wanted to set all of that up so I could give a couple of different examples from my own work, but I'll roll through these kind of quickly, but we can come back to any of these in questions if you like. So first, an example of a business case analysis. I did this work in the VA with the Durham Function Query program, and we were assessing an intervention to improve post-hospitalization outcomes for veterans called the Assisted Early Mobilization for Hospitalized Older Veterans, or STRIDE for short. And this really fits in with the age-friendly health systems movement in the VA because it targets an aging population and accomplishes the mobility goals. We're focusing on improving mobility during hospitalization with this STRIDE program. So as a part of the business case, understanding how it fits in with the VA priorities for veteran health and the age-friendly health system was really important. And a little background on the intervention, where we're aiming to optimize the physical function of older adults. And that was through supervised walking within 24 hours of admission. And it was dedicated STRIDE staff conducting these walks. And the initial randomized control trial found positive results through increased discharge to home and decreased length of hospital stay. And so because of this benefit to the population, the VA was really interested in expanding and disseminating this program. And it wasn't so much about, is this cost effective? Because we can see that it's high value, and that's a part of our mission, is to improve outcomes for veterans. It was more about, is this feasible? What should the budget be? And what types of implementation strategies are going to be most efficient for expanding access to the STRIDE intervention? So that is why we focused on the budget impact analysis as a part of this larger business case analysis to support decision-making by VA administrators. So our objective was to use the data from 8 study sites to estimate the resources needed to support implementation as well as delivery costs. So we had 2 separate buckets of costs that we were focusing on. And the 2 implementation strategies that were implemented in that study was replicating effective programs, which was the lower intensity implementation support. And then, so 4 sites received that. And then the other 4 sites received that the replicating effective programs, plus an additional team-based communications training called Connect. So that was a much more intensive implementation support. And so we wanted to understand, what is the difference in resource use if the VA were to choose one of these strategies to expand implementation across the nation. So the relationships that we're looking at here are the implementation strategy of REP, or REP plus Connect, and how those 2 groups look or compare in terms of their cost and also their enrollment. So we knew from the original trial that there was most likely going to be a benefit to veterans of the intervention. So we're focusing on this analysis on the implementation outcome of REACH, or how many people were able to access and participate in STRIDE in Connect versus REP. These were some of the assumptions that we made to take those 8 study sites data and then expand that and project what that might look like in a national scenario. So this is very much a what if scenario where we're projecting from those 8 sites what implementation might look like at the national level. And so our key findings were that STRIDE is a low-cost intervention to deliver. So if we just look at the delivery cost, we estimated $26 per enrolled participant, so per veteran who gets those walks in the hospitalization. And the program enrollment has the biggest impact on resources needed to deliver STRIDE, which makes sense. The more people you're trying to help, the more it will cost. And the implementation strategy, that decision might impact the REACH or enrollment, or the number of people who benefit. The big takeaway on the implementation cost were that the implementation costs were likely to exceed delivery cost in that first year. So in thinking about a budget, you really want to think about those implementation costs and how you can be efficient, because that's going to be your real cost driver compared to the delivery. So we can come back if people want some more detail here. I think the slides will be posted. I did want to mention that, in this scenario, we had wide uncertainty in our estimates because we only had 8 sites, and across the nation, sites can look very different. So we used a wide uncertainty range here, but we did see uncertainty in both cost and enrollment, But overall, the increased cost for implementation was likely to increase the number of veterans reached. So if you look at that implementation cost as a cost per enrolled participant, we actually found that the more expensive program, Rep Plus Connect, had a lower per participant cost. So it's $66 per participant. And this is just an estimate from those 8 sites. Again, very wide uncertainty here, compared to 118 in the rep only condition. So in the business case, we put together all these different pieces of information, and also the potential savings from a reduced hospital stay to support VA decision-making and potentially expansion of the STRIDE program. So the next example that I'd like to give is in cost effectiveness analysis. And again, this is in the context of the VA and another function query project, the stepped exercise program for knee osteoarthritis. And there was a randomized controlled trial evaluating this intervention we refer to as STEP KOA. And they found, okay, this is background on people who have knee osteoarthritis and how important it is that they receive physical therapy to improve their function. And in this trial, we had 2 sites with 345 veterans who were symptomatic. And then we looked at outcomes at 3 months, 6, and 9 months. So this is a relatively short time period to assess outcomes. And we, just to give a little background on the actual intervention, people enrolled would initially receive access to an internet-based exercise program. And then those who needed additional support, so as they were evaluated over the period, if we weren't seeing the improvement, then they would go to the next step and receive telephone-based physical activity coaching. And then there was another level for people who still needed additional support, the physical therapy visits. So we talked earlier about the limited workforce, and physical therapy is one of those areas where there's often more demand for the services than we have specialists to support. And so one of the benefits of this intervention was that we could tailor the program so that the people who most need that resource and that skilled expertise of physical therapy would have access to it, and we could better use those resources more efficiently. And so we were able to build that into the cost analysis and look at different probabilities of patients moving to those next steps. The primary analysis in the randomized control trial, they found that function and symptoms were improved. And so we added the evaluation of health-related quality of life with this cost-effectiveness study using the EQ-5D and compared that to the standard of care. So we did find it improves quality of life in addition to the other outcomes, reducing knee osteoarthritis pain. And we found a 99% probability of cost effectiveness using the lowest threshold in the US, so the $50,000 willingness to pay. So this is a very high value program compared to standard of care. And we also looked at, what is driving the cost of that program. And we found that because the trial paid for the mobile health devices for people to access that online service. And so as ownership of mobile health devices increases, the cost to implement the program should go down. And a little more detail, this just shows the quality of life changes over time. And while you can see the confidence intervals for quality of life overlap at each time point, the incremental change in the treatment group between baseline and 9 months was significantly improved compared to the incremental change in the control group over that same period. So that's where we derived the benefit and estimated the quality adjusted life years for our incremental cost effectiveness ratio, which was less than $10,000, very cost effective. We looked at the different drivers of cost, and a one-way sensitivity analysis, and found that quality of life has the largest impact. So really identifying those patients who will benefit from the intervention is going to be the factor that drives the cost effectiveness overall. So I've just got one more example to share with you, and then I'll open it up for questions. The third example is another cost effectiveness analysis, evaluating a palliative care trial that was focused on people with advanced heart failure who had recently been hospitalized, so recruited in the hospital. And it was palliative care provided in the community, so people who were discharged home from that hospitalization. And if you're not familiar with heart failure, it's highly symptomatic, and often people experience challenges with mental health as a result of their declining health and other factors. And so palliative care has been found to improve quality of life as well as reduce depression and reduce hospitalization. I included a couple of the studies in the literature around that. So in this particular study trial, they were evaluating a team-based palliative care provided in the community setting. And when I was conceptualizing the cost analysis and what questions we wanted to answer, I was really interested in informing payment for palliative care. So there's a lot of prior work that shows that this is a high value intervention, and yet in the CMS context, at least, the reimbursement is pretty limited through Part B. Especially when you think about an interdisciplinary team, so many different providers who are working together to provide this really tailored, high-intensity support for individuals as well as their families. So because of this, palliative care is often provided at a loss by health systems and providers. And so I was hoping to answer the question, if Medicare were going to pay for this type of interdisciplinary palliative care, what should they pay? What would a reimbursement look like that would be supported by a willingness to pay and cost effectiveness threshold? So we compared the likelihood of cost effectiveness at a standard $50,000 willingness to pay per quality. And then we also ran scenarios assuming that CMS was not willing to pay anything for additional quality adjusted life years. And we use that threshold because there have been demonstrations in the CMS Innovation Center for Palliative Care where they set an expectation of cost savings for dissemination of those interventions. And so we wanted to understand how that different threshold of expecting cost savings compared to being willing to pay $50,000 for a quality adjusted life year like we are in other intervention states, and understand how that might impact decision making. So while you might not find cost savings, which would mean you wouldn't implement the intervention, if you were willing to pay $50,000, then maybe you would implement the intervention. And so here is our primary results. We looked at the relative utility gain in our trial, and we looked at a range because this is what we always do in economic analyses. We always have some uncertainty, and so we want to look at a range. And we looked at the utility gain of 0.05, which was the study period average. And then we also looked at the difference at the end of the intervention at 24 weeks, which was quite a bit larger. So if that difference were sustained, then that would be the most relevant estimate to use. And over that range, the monthly reimbursement that CMS would be rational to reimburse ranged from $100 per member per month to almost $300 per member per month. And this is assuming that the intervention has no effect on hospitalization. So we didn't factor in any savings from prevented hospitalizations. This is just driven by the quality of life benefits from palliative care. Now, of course, in scenario analyses, we also looked at reductions in hospitalizations that were found in the trial, though due to our small sample size, they were not significant. But this has also been documented in systematic reviews that palliative care and heart failure has reduced hospitalizations. So we looked at a range of potential reductions in hospitalizations. The first set of bars here assume no difference in hospitalization. The second set assume a moderate reduction. And the third set assume the reduction that we actually observed in the trial, which was not significant. And so this bars represent the probability of cost effectiveness, which is the the solid blue bars, as well as the probability of cost savings, which are the striped bars. And so your probability of cost effectiveness using that 50,000 willingness to pay is always going to be higher than the probability of cost savings. But across all of these scenarios, we find very high probabilities of cost effectiveness, very high value service, and the potential for cost savings. And the potential for cost savings increases with the prevention of hospitalizations. Just to summarize, outpatient palliative care and heart failure was cost effective in this particular trial, and in the larger literature, growing evidence finding that as well. Potential for cost savings, as long as we're identifying those patients who are likely to benefit. And I think that's a really big question in palliative care right now, is how do we identify eligible patients and who is most likely to benefit, and how can we tailor the intervention to optimize those outcomes. All right, so just wrapping up here with a quick summary of those three different examples. The STRIDE hospital mobility program, we use budget impact analysis to inform the VA decision-making. And because health systems and administrators are often focused on that next year, that next budget cycle, we used a 1-year time horizon and evaluated what will it cost. And in STEP KOA, also in the VA context, and informing VA decision-making, but we're focusing on what is the cost relative to the benefits in the standard of care. And we used the trial time period, which was less than 1 year in that scenario. And then in PAL-HF, again, cost effectiveness analysis, but informing a very different decision maker. So thinking about the federal payment and payment models. Because of that, we wanted to look at a longer time horizon. So this was we simulated those outcomes from the trial, which was shorter. I think it might have been 6 months. And we projected those out over the lifetime for that population, which was about 3 years. So we answered the question, what should we pay as a society? What should we be willing to pay for the value of this intervention? So thinking about who is the decision maker can inform a lot of the different decisions that you need to make in designing a cost analysis and how you want to approach those different questions. So for providers, often a shorter time horizon is going to be more relevant as they think about feasibility and planning for their budget. Often in those, for that decision maker, you have a more limited definition of cost. So in a perfect world, we would look at the cost for everybody. But if you are a hospital administrator, what is really going to make your decision is what are the costs to my organization and what is the revenue that I can use to offset those costs. Because while we know hospital systems are doing their best, no money, no mission, we need to have a sustainable program. So budget impact or business case analysis, very important, I think, particularly, as the field of implementation science continues to grow, we have a real opportunity to use those types of analyses to support implementation and inform adaptation of programs and interventions to new contexts. And so moving into cost effectiveness, we're often thinking about decision makers for a payer like Medicare or Medicaid, the VA. So thinking about a larger system. So because of that, we have to have a broader view of cost. So incorporating cost to patients is really hard to do, but also really important. So those are some of the challenges that we face. And then ideally, in the societal perspective, we're including all costs incurred by all parties for a lifetime time horizon. So it's very hard to do, but really important to aspire to that ideal. So that kind of leads very well into some of the limitations of cost effectiveness analysis. So lack of data, certainly one, and trying to find estimates for those different costs. So a couple other limitations, simulation, we're forecasting based on current knowledge. Things can always change. Nobody expected there was going to be a pandemic. So a lot of those forecasts changed really dramatically. If you're, in some context, if a really complicated model can feel like a black box, you're putting in a lot of data, a lot of inputs, and it can be hard to understand which factors are impacting which outcomes. It also requires a lot of assumptions. And so ecological fallacy, obviously we're estimating at a population level, which can inform individual decision making, that every individual is going to have their own risk factors and their own preferences and their own value priorities. So that shared decision making between the provider and the patient is not going to be replaced by cost effectiveness analysis. Those conversations are really important. Limitations on quality measures as well as cost measures. And then an important aspect to consider is equity as well. So anytime we think about cost and benefit, you want to think about who is paying the cost and who is benefiting. And if those aren't the same groups, then that's a health equity problem. And coming back to the benefits, obviously I do a lot of cost effectiveness analyses, and I do see a lot of benefit in being able to have a single measure that incorporates the cost and the outcomes on the health side to understand the value proposition for an intervention. So despite all the limitations, having that single measure can support decision making and allow us to compare the value of interventions across very different contexts. So we can compare, a new chemotherapy regimen for cancer patients to a new device, transplantable device in heart failure, and understand the value in those very different populations that we couldn't test in a clinical trial. Like that wouldn't even make sense. So I think that's a really benefit. Since we do have limited resources. So I'd love to open this up for questions and discussion. I think hearing about any of your experiences using cost analyses or questions about what I shared today, really appreciate your contributions here. So Amara, I don't know if you have been watching the chat, or I can look at it now.
I have.
Yeah.
Dr. Furman asked a question, but you answered the first part. So she would like for the second question to be answered, which I think is, where do you see the U.S. health policy changing in regard to hospice and palliative care?
I appreciate the opportunity to talk more about that. Christian, did you want to elaborate? Thanks for coming on camera. Oh, are you muted?
You're muted, Dr. Furman.
Oh, perfect. Sorry, I'm not used to this format, but you all can see and hear me okay. Thank you so much for presenting, Brystanna. Brystanna and I are health and aging policy fellows together, so I know peripherally about your work, so it was great to learn more about it. So it was very, very helpful. But yeah, I just think, being on the Hill, we've heard some rumblings that, they keep talking about changing the hospice Medicare benefit, or, maybe making palliative care actual benefit. Where do you see that going? Have you heard anything about that? Or do you have any insights on where hospice and palliative care is going with this U.S. health policy?
Yeah, that's a really great question, Christian. So, data on the value of outpatient palliative care definitely growing and increasing. We have a lot of evidence in the inpatient setting, a lot of evidence for hospice, and increasingly, we're seeing the value of providing those supports earlier in the care trajectory. And the movement in U.S. health policy is definitely focused on those high value interventions. And so palliative care is in that bucket. I think the challenge is in identifying the patients who are going to benefit from that intervention, and also preferences, the people who want palliative care as a part of their care benefit. And so just to clarify also for people who may not be in the palliative care space, we're talking about palliative care upstream that is concurrent with curative therapy. So you're still receiving all of the specialty support that you would normally receive for your diagnosis, but then also receiving more emotional support, symptom control, medication management, connections to social services, caregiver supports. So, this really holistic care model. And so many patients do experience benefit, but it's not, because it is so tailored to the individual, it's really difficult from a policy perspective to standardize the way that we often do in other payment models. So, if you're coming up with a bundled payment for stroke care, yes, there's a lot of variation in strokes, but we can, define, what is needed for that stroke care, and then what we're going to pay for it. And in the palliative care space, we're not to that point yet with the evidence, and we haven't built consensus around what is the eligibility for palliative care, what are the different levels of intensity leading up to hospice, and then what are the specific services that should be included, and how can we be flexible in a payment model that still allows providers to tailor and meet the needs of different individuals. And so, of course, social determinants of health are an important factor to consider in that tailoring of the program too.
Yeah, because it seems like there's, like you said, I didn't think about it this way. There's definitely been a lot more research in the inpatient and palliative care in the inpatient it's not the same as palliative care in the outpatient. So you can't really extrapolate, so that we just don't have there's not a lot of outpatient clinics really, to even study out there. So the VA, thank goodness, has more than, others, but yeah, that's a good point. So just maybe a little more time to get more data, and then, yeah.
I'm excited to have that data from the VA because it is so much more, there's more documentation, whereas in Medicare, because it's not well reimbursed, people don't bill for it, and therefore we don't know who's receiving palliative care, who's not, or what they're receiving if they're receiving palliative care.
Right.
So hopefully this work in the VA will be useful to the context outside of the VA as well, since we really have very little information. But the setting of palliative care, like you said, really important. Think about inpatient, outpatient, but then also assisted living and skilled nursing facilities. So
right, that's a huge other field, right? Yeah, very interesting. Thank you so much. I was hoping it would be like this year. No.
TBD. To be determined.
Yes, it's too early. And the VA does have nursing home. I'm sorry, are there other questions, Amara? I don't want to.
No, not right now. I haven't seen anybody say anything yet.
I was just thinking, also the VA does have nursing homes. I think they're called I don't know what they're called, continuing
Community living facilities.
community living facilities. But I wonder if are they studying palliative care in those facilities? I don't know. I haven't heard much about that.
Yeah, so I do have that in my data. So I will look forward to answering the questions about how palliative care is being accessed, at least in the VA, on the VA side.
Right.
Yeah, so lots of very good questions. And I think the very strong consensus between stakeholders and policymakers is that there is a gap. So it does need to be addressed, whether it is this year or in the future, that there is a lot of need for additional supports in serious illness care, where illness is very advanced, but it's not time to consider hospice yet. So there is a gap where palliative care can fill and bridge, layered on top of curative therapies. So that is very clear. And the question is really about how can we design a payment model to incentivize and fairly compensate providers for those services in a way that is high value.
Donna,
and Dana, yeah.
I was like, she wrote in the chat. Can you go over again the dollar amount assigned to the year of life?
Yeah, Dana, did you want to come on camera and elaborate? Are you just curious about the willingness to pay values? Because I can talk a little bit more about those. So the willingness to pay thresholds are exactly what the title says. So how much would we as a society be willing to pay for an additional quality adjusted life year? And that can vary a lot between different countries and even within countries for different contexts. And it's somewhat related to your GDP. So countries with a higher GDP will typically have a higher willingness to pay and have a lot because they can afford higher value for healthcare. And so in the United States, historically, $50,000 was a reasonable accepted amount to pay for a quality adjusted life year. But more recently, the last 10 years, we've seen an increase in that willingness from policymakers, from health systems and payers to pay more for those really life-changing, life-saving therapies. So if you're thinking about cancer treatments, some of the really innovative, novel interventions that have come up with, and this is not my area of expertise, so probably saying things wrong, this gene-based therapies that are really expensive, precision medicine, and I think in dementia, there are also some expensive therapies because these are seen as such high value in our society. The willingness to pay is often higher. And so we've seen, $100,000 willingness to pay, $150,000 willingness to pay for some of these really innovative therapies. And I think a part of that makes sense because we want to encourage innovation. And over time, those really new expensive therapies the price will come down over time as there are generics, as we standardize the process, and we've recouped some of those upfront costs. The cost will come down. So there is an economic rationale to some extent. But the trade-off to that is there's a question of equity. If we're willing to pay more for some really expensive therapies where maybe the patient copay is really high, or maybe you have to have a rather expensive level of insurance coverage to qualify for those different therapies. So it's just something to consider, in that decision-making process as we're setting what is our willingness to pay for different contexts. Are we benefiting some groups more than others? Sorry, that was a really long answer, but is that helpful?
It's like the monoclonal antibodies, that is like with Alzheimer's drugs. The new monoclonal antibody, you can only get it if you're part of a clinical trial because that's the reason I think that CMS wouldn't pay for it. It was just so expensive. And so there was some question of, is it work or not? Is the risk benefit, is it make enough clinical benefit to justify the risk? And it's really expensive. So, were they willing to pay $50,000 or $100,000? It's really, that's a great question. What are we willing to pay for a quality adjusted life year?
Right.
Yeah.
It's a great example. Thanks.
Yeah. Let me ask you this too, and if anybody else has something, please. But since I have Brystanna, I'm going to pick your brain. So, what about what you were talking about, how palliative care being offered at the same time as curative care, right? And can we do that? And that's what we're trying to figure this out. But it actually happened with peds, right? With children, they are doing that now, is my understanding. Do we have data from hey, did it save money, cost money? I know peds is just a whole different ball of wax, but is there any data on that now that's coming out, since it's only been going on maybe a year, 2, 3, something like that? Is relatively new.
Mm-hmm. There are. So the context where palliative care has become really well integrated into the care model, I would say, are cancer specifically, and in pediatrics, I think cancer might be one of the driving diagnoses. At peds, in thinking about cost effectiveness, pediatrics is a really different context, because the life expectancy in that group, there's so many years of life expectancy that would have been possible without that diagnosis, right? So anything that can be done to increase likelihood of survival is hugely valuable. So it is a very different, unique context. I want to acknowledge that. I have not specifically focused on palliative care in pediatric populations. But because of that, I think it would be considered higher value, and obviously a really high need for those special populations. So.
And then maybe that's why they did it, right? Because I didn't think of it that way. When you take it analytically, like just the life years, it's a huge amount, right? So it's worth it. That makes sense. Mm-hmm. And you see Dana's comment seems very about the quality adjusted life year is very fluid based on the country, etc. Yeah, how much money they have to spend.
It is. Yes. Thank you, Dana, for the question, and Kristen. Really glad we had this opportunity to share. A welcome follow-up after this meeting. Put my Twitter handle on the slides, but maybe not my email, but you can find me.
Brystanna, this is really helpful. Yeah, you did a great job of explaining the complex analysis. So
spread the word.
Yeah, examples.
Love to see more cost analyses, and particularly supporting implementation dissemination. So, thank you for this opportunity.
Enjoyed it. Thank you.
I just want to let everyone know, thank you for joining us for the improved value of care for aging breakout session. I would like to remind everyone we appreciate your feedback, and this session is eligible for continuing education credits. Please complete the evaluation for this session contained in the email that you received this morning with the subject line OAC 2023 post-session evaluation link, April 15th to the 18th. Thank you again.
So Amara, should I hang on, or are we wrapped?
We have 2-3 more minutes. If anyone else has questions, and they're more than welcome to ask now.
Well, thanks, Amara. This is
You're so welcome.
Great session. Very smooth technology. Always appreciated.
Thank you.
It was nice to meet you. I'll go ahead and drop off then.
Okay. You have a great day.
Bye.
Bye.